Thanks very much, Mel. And just to maybe address a couple of the new board members and members of the public, the reason I'm standing at a podium, which is perhaps not normal for a board meeting, is because although this is a typical quarterly report from me to the board, it's also an opportunity for me to address members of the public, either here in the room with us today or on the webcast, as I go through the sort of detailed performance results of the organization for the year 2018-19. So although we're well into the 1920 fiscal year, this is also our year-end report for the prior fiscal year. And Mel, of course, if board members have questions as I go through, if I miss a hand signal, please just stop me and I'll take questions as I move through my presentation. So building on what Mel said, there were a number of very significant achievements in the past fiscal year, and I've listed here just 3 or 4 that really occupied a good percentage of management's time over the past year, one of which was the development and launch of our new brand, which of course is exemplified in the logo, but it was much more than just about a physical rebranding of the organization. It was about a fundamental repositioning of our corporate statements, our mission, vision, values, operational pillars, and our quality policy, and also about reflecting where the organization has evolved in the past 2 decades as we've gotten more and more involved in the transplant world. As you heard from Renee, our work spans both transfusion and transplantation, medicine and science, and it was time to refresh and modernize our brand to reflect all of those changes. So we proudly launched the brand on our 20th anniversary last September, and I'll show you some results from that in a moment. Mel talked about the strategic plan, and you're going to hear from one of our directors, Christina Island, later on in this meeting about the content of the plan, so I won't speak any more about that. Perhaps a little bit of inside baseball, I recognize, but one of the initiatives that occupied a lot of management's time this past year was the development of the National Accountability Agreement, which is our agreement with the funding provinces and territories that are the members of Canadian Blood Services that modernizes and refreshes the governance relationship in terms of how this organization operates on behalf of the members and how we commit to deliver a sustainable system on their behalf. So led by Judy's group and Pauline's group and Ron's group, a good deal of effort went into the creation of the National Accountability Agreement. And just to update the board, that agreement is actually now out with the 12 governments. They've all received it. We essentially have agreed on the final terms of that agreement as the board saw at your last meeting, and the various jurisdictions are now meeting with their officials and ultimately with the objective of getting ministerial approval in each of the 12 jurisdictions, and we are working very closely with the lead province, Prince Edward Island, to have that agreement signed within this calendar year. So that remains the intent, and at the moment we don't have any red flags to suggest that that won't be achieved. And then, as Mel said, one of the major achievements of the year, of course, was the launching finally of our proof of concept plasma program, and this was about getting agreement and funding from governments to launch the first 3 of our plasma collection sites, and we'll talk more about that later on as well. The next couple of slides, and I hope you can see at least a couple of the headlines here. I don't intend you to read the small font on these slides. But the next 2 or 3 slides are just some data that we gathered both before and subsequent to the launch of the new brand. This one looks at what the Canadian Blood Services staff view of the new brand was, and there's a couple of important data points here. In September last year, just before the launch of the brand, we asked the organization if they saw value in the brand renewal and what we were seeking to achieve with the refreshed brand, and about half of the organization thought that that was beneficial. 6 months later, so just at the end of the fiscal year, we went back to the organization and asked again if they saw value and benefit from the various aspects of the brand renewal. And you can see that more than 8 in 10 employees saw the brand as delivering added value for the work that they were doing. So that was a very encouraging sign for us. Not only did the brand help improve employee engagement, but I think you can draw from these data points some comfort, board members, that the organization actually saw a positive value in the brand in terms of individuals doing the work that they do. Another way of looking at that in a little bit more detail is on this slide here. We asked a series of questions of our workforce around their attitudes to the organization as a consequence of the brand. And both before and after the brand, about 90% of the workforce say that they understand the need for change in the organization. That's well understood. But it's the latter two data points on the slide where you can see a big lift from the September data to the March data. So firstly, what employees reflected back to us was that they felt that the new brand helped align the culture and practices of the organization, both internally and externally. So they saw a linkage between the messages and the brand we were trying to reflect to our donors and to our stakeholders as much as they saw it for themselves inside the organization. And importantly for us was a recognition, the last data point, that the brand helped communicate a clear direction to the organization. So they felt that all the work we did as a consequence of the new brand as senior management helped communicating where the organization is seeking to go. So we thought that those were two other important data points. And the last one I'll show you on the brand is on this slide here. As the board knows, one of the major elements of our brand renewal is the refresh of new corporate values. We have 5 values that go by the acronym I CARE: integrity, collaboration, adaptability, respect, and excellence. And we asked individuals in the organization whether they felt those values either helped them model how they behave at work, whether they align with their personal values, or whether they make their decision-making inside the organization clearer and easier. And you can see that essentially 90% of the workforce agrees with all of those statements. So those are just a snapshot. We have a whole lot more data. We're happy to share with the board if you wish, but a whole lot more data that shows that the value of the brand inside the organization was very positive. This is the only data point I'll show you of the value of the brand 6 months into its launch from outside the organization. And this is a bit of a busy slide, but it shows an important message that we've talked many times about at the board table in the past, and that is whether our brand, Canadian Blood Services brand, is being distinguished in the minds of Canadians. And this is speaking to all Canadians in general, not committed donors who obviously have a particular affiliation with the organization. And as the board knows, and we've grappled with this one literally for 20 years, is we are still fighting the recognition battle, if you want. When you ask Canadians unaided, and that's the important word here, this is not prompted, this is no clue given, but if you simply ask the question, who runs the blood system, who's responsible for managing and running the blood system in Canada, and you don't give any clues, for the very large majority of Canadian Blood Services existence, the Red Cross has been the dominant answer, which is not surprising given that they ran the blood system in Canada for 50 years before we came along, and the Red Cross is such a powerful brand and symbol in public's mind. But if you look at the very right-hand set of bars here, you can see that at the end of 2018 and the spring of 2019, there was a significant uptick in Canadian Blood Services as the answer to an unaided prompt as to who manages the blood system. And the first time ever we've seen a delta of 14 percentage points between ourselves and the Red Cross. They were down at 26, and the answer, Canadian Blood Services, was up at 40. So we, Ron and I and many others, are still not satisfied that this is the level of unaided awareness, but I think it does show that the new brand helped provide a bit of an uptick there, and we know that there is still more work to do in this domain. What I want to do now, Mr. Chair, is move into some performance results for 2018-19, and I'm going to do it program by program. So I'll first speak by blood, then plasma, stem cells, organs, and tissues. And I just want to provide a snapshot of the performance results for each of our major product lines. So Of course, this is just to remind us what our role is in blood. We are the operator for the National Blood Program in all provinces and territories with the exclusion of Quebec. And this means everything from recruiting donors, collecting, testing, manufacturing, and distributing all fresh blood components to every hospital in the country outside of the province of Quebec. So just at the highest level, 2018-19 was a very successful year from a recruitment and collections point of view, and we exceeded our collections target by just over half a percentage point. And that might sound trivial, but you don't actually want to overshoot your collections targets by much more than that, because you're then going to land up with more blood than you need and you run the risk of outdating it. So getting as close to the forecasted demand target as possible is important. And as the board knows, sometimes we only come within 98 or 99% of that. But for 2018-19, we actually hit and exceeded our collections target, which meant that we were able to operate the entire year with a very solid inventory, and we were able to consistently meet hospital orders at all times for all fresh blood components, red cells, platelets, and plasma, including for the high demand groups such as O-negative red cells or AB plasma. Again, I'll show you a couple of slides on that, but as a headline, that's a pretty important achievement. And another one, which I will show you data on in a couple of minutes, is in 18-19, we not only met, but we exceeded all of the productivity targets that we had set for the organization across the four main dimensions of the supply chain: recruitment, collection, testing, and production. So a couple of slides to unpack those headlines. This is the slide that talks about our ability to deliver red cells to customer hospitals. And of course, red blood cells are the dominant product that we deliver into the marketplace. And as you can see on this slide, if you look at the last 5 years and you just look at the blue bars, there's a downward trend in the number of red cells that we've been delivering to hospitals. This is not a failure to meet numbers. This is a trend in clinical practice that we've talked to the board many times about in the past, that the demand for red cells continues to go down in most developed countries. And it's going down because of improvements in surgical practice, improvements in medical care, and this whole discipline of patient blood management, where physicians and surgeons have become much more adept at optimizing the way they deliver transfusion therapy. So it's a declining demand based on improvements in clinical practice, but we've been able to completely meet that demand. The red line is an interesting line. It's a metric that we call red cells issued per 1,000 population. And we measure it because we actually benchmark ourselves against other similarly developed countries. And that's shown on this slide here. So the red line on the previous slide is the same red line here. But we compare ourselves to other jurisdictions in terms of what is the rate of use of red blood cells in Canada for patient care compared to other developed countries. And you can see that the acronyms here: NHSBT is the blood transfusion service in the United Kingdom, ARCBS is the Australian Red Cross Blood Service. And so you can see Canada, Australia, and the UK are essentially identical. We're all seeing a downward trend, and we're all transfusing at a rate of around 26 or 27 red cells per 1,000 population. The top line is the American Red Cross, which is the US data. That represents about half the blood supply in the United States, but it's true for all the other blood operators. And you can see in the United States, they use red cells at a much higher rate than we do in Canada. Yes, they're coming down, and they're coming down quite steeply, but they're still transfusing at about 35 red cells per 1,000 population. And I don't want board members to interpret that as a good thing. That's actually, they're trying to catch up to where the Commonwealth countries are. Kelly. Next button. You had it on. Yeah, there you go.
Graham, do you see this trend continuing, or have we bottomed out?
Yeah, so I wish I had a crystal ball to really answer that. We talk a lot at the ABO table, so the Alliance of Blood Operator table, which comprises all these blood services. We're all asking the question, what is the nadir here? Where do we think we will plateau? And it's an important question because really that defines our service delivery model. We need to know what sized organization, what size donor base, what size network we need in order to make sure we collect just the right amount of red blood cells. I believe, based on clinical trends and all the sort of objective forecasting data that we and the other countries have here, is that we're approaching a period where it's going to slow down. The rate of decline is going to slow down, but I don't think we're at the bottom yet. In Australia, there's an interesting set of data. In Western Australia, they're transfusing at 22 red cells per 1,000 population. The rest of the country is a little bit higher. We don't have quite that variation across our provinces, although some provinces are transfusing at 23 or 24 and others at 26 or 27. What is more scary is for the Americans and the Europeans who are transfusing at 35 and 40. In Denmark, they're transfusing at 45 red cells per 1,000 population. I didn't show it here. Because they're terrified that if they get to the rate where Canada, Australia, and the UK are, that they will have to halve the size of their organizations, their donor bases, and their physical footprint. And that's a dramatic impact on any organization. It's also, of course, another reason, as you know, Kelly, why we want to leverage our infrastructure and get into the plasma collection business. But to answer your question, I think we're approaching the plateau phase. I don't think we've hit it, and I think it's probably a couple more years before we know that for certain. This data is platelet shipment, so that's the other major fresh blood component that we collect and manufacture. And just 2 or 3 data points I want to show on this slide. The combined bar, the red and the blue together, is the total amount of platelets we deliver into the marketplace. And there's competing factors at play here. Firstly, the actual demand for platelets continues to go up, unlike red cells that it's going down. And it's going up because we're seeing more stem cell transplantation, more oncology care, and cardiac surgery is a big consumer of platelet products. So actually there's more platelets being used, but the reason the shipment number, so that's the amount that we ship out to hospitals, has gone down is because in the last couple of years we've done an enormous amount of work with the hospitals to reduce their wastage of platelets. So they had, in some hospitals, a wastage rate as high as 20%. So we were shipping product and 20% of the product was never making it to the bedside. It was just outdating because of its short shelf life. And as the board knows, in the last year and a bit, we extended the shelf life of platelets from 5 days to 7 days, and that had a dramatic impact on the wastage rate. Plus, we're working with our customer hospitals, and they're putting in many programs and protocols to better manage the inventory that they have available. So although it looks like we've shipped less, we have. The rate of use is, if anything, going up slightly. And we expect that to increase in the next couple of years because we've dealt with the wastage factor, although we still believe more can be done there. So that's the first data point on this slide. The other one is just to show you that the red bars are shrinking, and that's by design. So the red bars are the more expensive platelets that we collect, the so-called apheresis platelets, where we hook a donor up to a machine and we collect only platelets from that donor. The blue bars are the platelets that we make from the whole blood unit that we collect, the so-called buffy coat platelets. Buffy coat platelets are way less expensive to produce and just as efficacious. And in fact, there's some data to show in some circumstances they're actually better for patients. So we've intentionally reduced our collections of apheresis platelets and increased our collections of whole blood platelets. So that was by design, and that was an efficiency objective of ours. And lastly, on the fresh blood component side, this just shows you the plasma shipments to hospitals. Now, just to be clear, this is not plasma products. This is fresh frozen plasma. And you can see this has continued to decline over many years. In fact, I could have trended this graph back another 5 years and you would still see a decline. And the reasons for this is, again, a change in clinical practice. Physicians are using a different product now, a product known as a prothrombin complex concentrate and another product called solvent detergent plasma. And there have been various changes in clinical practice. For example, in patients who have motor vehicle accidents and severe trauma, the so-called massive transfusion protocols where patients get hundreds of units in a short amount of time, they've switched away from using plasma to use fibrinogen concentrates instead. So changes in clinical practice have driven this decline in demand.
Graham, do you want to just address or help me understand the change in clinical practice, and you going back to the slide with the differentials across countries? Is there a difference in clinical practice between Canada and the United States, for instance?
So I think the answer is a little bit of yes and no to that, Mel. They tend to have a less restrictive approach to transfusion than we do. And I speculate, as do many of my clinical colleagues, that dates back to the years of the tainted blood scandal in Canada. And I remember when I was on the transfusing side of the business in the early 90s, Canadian physicians became really good at minimizing the amount of red cells that we delivered to patients because there was such a fear in the sort of late 80s and early 90s that it drove a very disciplined approach to transfusion medicine. There was also a major Canadian study in the 90s, the TRIC trial, that really helped show you could keep patients at a pretty low hemoglobin and still keep them healthy. Whereas I think in countries like the US and certainly in many of the European countries, they have a much more liberal cutoff before they will transfuse a patient, so they don't take the patient as low. So I think there are indeed different practices and protocols. There's also, let's be honest, if you compare a country like the United States to Canada, there's considerably more trauma. So if you look in the major centers where there's a lot of gunshot injury, for example, we know that they use a lot more red cells, for example, in those jurisdictions. So there's so many factors at play. I think there are broad spread clinical practices and clinical guidelines. There are disease categories and things like trauma that might drive different utilization rates. And then I just think there are sort of long-standing practices that have become the norm in countries. That doesn't mean they don't do fantastic patient blood management in the US. They do. But I think they just have a different approach to transfusion triggers than we do. The next, so that's sort of a snapshot of the year in terms of how much product we've delivered into the marketplace. The next two slides are important data, and I know this is a little bit of a busy slide, but I unpack it on the next one. As the members of the Safety Research and Ethics Committee know, and you dig into this data more in detail in your committee, Anne, but I want to just highlight for the board and for the public the important surveillance results. So, of course, a major part of the work that we do is a safety and surveillance analysis at all times. We're constantly monitoring the blood supply from a safety point of view, and we use a lot of surveillance data to do that. This slide shows at a very high level the number of positive donors for the three major viruses, HIV, hepatitis C, and hepatitis B virus, for 2018-19. And if you just look, there's two rows in the table. The first row is the first-time donors, about 100,000, and the second row is the repeat donors. And we break the surveillance data out because typically you expect a first-time donor to have a much higher infection rate because you've never screened them before. A repeat donor who keeps coming back keeps getting tested, so the likelihood that they've got HIV or hepatitis C is much lower. The numbers for HIV are so inordinately low. We had no HIV in our first-time donors last year. We had one positive HIV in a repeat donor. But look at hepatitis C and B, and you can see that it is much more common in first-time donors, 51 versus 1 or 47 versus 9, than in repeat donors. And here's the same data tracked out for the past 30 years. And I only want to use this slide, again, it's a busy slide, but I want to reassure the board and members of the public that, and the black lines are the incidence in first-time donors, so the ones that really have the highest incidence. The red lines are the incidence in repeat donors, and they're so low that they look like they're pretty much at zero. But we not only calculate the incidence every year, we then do a very sophisticated analysis using a global approach to risk assessment, and it's known as the residual risk calculation, and all blood services around the world do a very similar calculation. We want to understand what the residual risk of a donor in Canada is of transmitting HIV, hepatitis C, or hepatitis B, despite all the tests and despite all the screening criteria that we have. And as the board knows, as well. It doesn't matter how many tests you put in place. It doesn't matter what questions you ask. There is still a risk of a virus breaking through the system for a variety of reasons. And those are the numbers in 2018 shown at the bottom of the table there. About 1 in 13 million HIV donations in theory could be 1 in 13 million donations could in theory transmit HIV, 1 in 27 million for hepatitis C, and about 1 in 1.5 million for hepatitis B. And those take into account prevalence data in the population and the sophistication of the tests that are used. Those numbers are exceedingly good numbers, and certainly amongst the lowest residual risk numbers of all blood services in the Western world. And lastly, on safety and surveillance, just to remind the board that last summer was a very busy year from a West Nile virus point of view. There was a big outbreak of West Nile virus across a number of provinces. We detected 42 donors who were positive for West Nile, which means obviously we didn't use their blood, and they were deferred for a period of time. And that is the second highest number we've ever seen for West Nile since we started testing 20 years ago in 2003. We had 1 year where there were 79 positive donors, but last year there were 42. A typical year is anywhere between 8 and 10 positive donors. And of course, as you know, we do a lot of other screening for other infections, particularly mosquito-borne infections, for parasites such as malaria, and this shows you that there were no concerns in the past year. And the board knows, because we've spoken to you about this in the past, but just to make sure that it's part of the record for 18-19, we did 2 very large seroprevalence studies last year, paying attention to 2 emerging pathogens. One is a parasite known as Babesia, which you get from ticks, and another virus known as hepatitis E virus, which is likely spread from undercooked or uncooked pork products. And both of these agents are of concern to the blood supply, certainly in regions of the world where you have very high prevalence of the parasite or the virus. So we undertook a study jointly with Hema-Quebec and the American Red Cross for both of these agents. We've shared the results with the board in the past, but since they were done in this year, I thought I would just close out the report to show that based on the seroprevalence studies that we did and the risk-based decision-making analysis that is been done for both of these pathogens, at this point in time, we don't believe there is any need to introduce a test for either Babesia or hepatitis E, but this is an issue we're paying very close attention to. Jeff?
Graham, I'm just wondering, pathogen reduction is coming, it's now a new theme. Where are CBS towards that in the future?
So in 2018-19, we kept talking about pathogen reduction. In 2019-20, this year, I'm pleased to say that, Jeff, management received a business case for the introduction of pathogen reduction technology. We had indicated to the provinces and territories through our last corporate plan that, for the corporate plan of the last many years, that when a suitably licensed technology was available in Canada for pathogen reduction, we would look to implement it. So there is now a suitably licensed technology in Canada. There is a company known as Cirrus that has a licensed technology for pathogen inactivation of platelets. And so we have done an initial analysis and we received a business case, and we will be introducing on essentially a pilot basis, so 10% of the platelet supply starting this year will go through this pathogen inactivation technology. So why only 10% and not the whole platelet supply? We still have to understand the implications of this technology. One, it's very expensive. Two is it has the potential to actually, when you treat a platelet unit with pathogen inactivation, you may render the platelets less effective, so they don't help the bleeding as much, which means you potentially need to give the patient more platelets. So it could have a dramatic impact on the demand or the amount of platelets we have to collect. So there's a lot of work to do from a logistics point of view, a costing point of view, an efficacy point of view, and simply an operationalization of this. It's not a simple technology. So we're piloting the technology. We will produce about 10% of our platelet supply this year through that, and we will use that as a sort of a demonstration case of what it would take to implement pathogen reduction for the whole platelet supply over time. And pretty much most countries have gone that way. That's typical, for example, in the US and elsewhere. There are a small number of European countries where it was mandated for the whole platelet supply, a couple or 3 countries where that's the case. And there are a couple of countries that have at this point said the health economics don't justify it at all. So the gain in safety is so small and the cost is so high that they're not doing anything. So both Australia and the UK are in that position at the moment. So we're all seeking to understand how this technology is going to change the paradigm, and that's why, we're taking it in this sort of test and learn approach. But this year we will begin to implement it for about 10% of the platelet supply.
Please, we're trying.
Yeah, no, I'm, as am I. As you know, I've been a huge advocate for because I do think it'll shift the paradigm, but it won't fundamentally shift the paradigm until we can do it for all fresh blood components, red cells and plasma as well. Because at the moment, if you're only doing it for your platelet unit, you're still going to have to test the donor and ask all the questions, and you can't get rid of any of that until you're testing until you're pathogen inactivation, everything including the red cells. So it's a bit of a slow process. What we might be able to do is stop doing bacterial detection if the pathogen inactivation is shown to be effective. So offsetting costs are a big part of it. I'm going to shift so that was fresh blood components. I'm now going to shift into plasma. And of course, just remind all of us that we have multiple roles in plasma. We collect plasma. We then contract manufacture that plasma. We bring back the finished products and we distribute those plasma protein products. Some of the plasma we collect is the plasma we need for transfusion purposes, which I've already showed you and dealt with. But then we also are responsible for buying a variety of plasma protein products on the global market and meeting patient needs. And I'll again hit some of the highlights there. Well, of course, the headline news for 2018-19, as I said at the outset and as Mel said in his remarks, was the fact that we secured funding and support from the provinces to advance our 3 standalone proof of concept plasma collection sites. So this year, 2019-20, we will be launching the first of those sites at the end of the fiscal year. Hopefully doors open on April 1 next year. We're in the sort of location analysis right now. We have a number of locations that we're interested in opening our sites in, but John Paul and his team, working very closely with Rick and his team, are just finalizing the determination of which sites across the country will be the first 3 sites where we launch these plasma centers. And of course, we're doing a huge amount of work to operationalize or to optimize the operating model. And so we're leveraging some of the learnings from the commercial plasma collection industry and from many other countries, including the Hema-Quebec, so Australia, Hema-Quebec, the Netherlands, and others that are ahead of us in terms of source plasma collection from non-remunerated donors, as Mel said. So a lot of work underway there now. And as I say, by the end of this year, we hope to have the first doors open of the first of our 3 plasma sites. The other piece of work that we did this past year was convert 2 of our blood centers, London and Calgary, where we have apheresis or source plasma collections. We changed the way we collect plasma in those 2 locations. We moved all the donors to what is called a large volume plasma donation. So instead of donating half a liter, the donor can donate up to 800 mils of plasma in a single donation, which makes it a much more effective and efficient process, and you get much more volume per donation. And you can see that just as a consequence of those 2 changes in London and Calgary, we've seen a 37% increase in the volume of plasma collected from those 2 sites. This is the data that we're chasing, and I only put this slide up to remind us why we're in the plasma collection business, and it's all about the growth for immune globulin, not only in Canada but internationally, and this notion of what is called domestic sufficiency, which is how much plasma do we have under our control from which we can make immune globulin versus how much immune globulin do we buy dependent on the commercial market, which is essentially the US market. And that's the green line. And as you can see, in the 7 years that we've been talking about this and longer now, the sufficiency number has dropped from 21% to about 13.5% this year. And so it is really urgent that we reverse this green line. And as the board knows, our long-term ambition, many years down the road, is to actually get that line to around 50% sufficiency. But the first order of business is to stabilize the decline and reverse it on a slow upward trend. And that's what the first 3 plasma proof of concept sites is intended to do. If I look at the actual products that we're distributing to our customers, there's several important pieces of news that I want to share. And of course, the rest of the open board meeting, you will be hearing from a variety of patient groups and patient representatives talking about a number of these products. But there is some important news for me to apprise the board of. Firstly, literally in the last few weeks, we received indication from the provinces and territories for approval of 2 products, panhematin, which is used to treat patients with porphyria, and emicizumab, which is the newest therapy for patients with hemophilia A who have inhibitors. It's a monoclonal antibody. It's an entirely new way of treating hemophilia A as opposed to simply replacing the missing factor VIII molecule. You're actually using a different form of therapy altogether. Those were 2 drugs that you've heard about many times at the board before. You'll hear about both of them this morning as well. And we made submissions to the provinces and territories after we did our work, and we collaborated with CADTH, the Canadian Agency for Drugs and Technology in Health, made our submissions, and they were approved by the funders. You will hear perspectives from the patient groups, but the good news is that both of those were approved. Importantly for emicizumab, it was approved for patients with inhibitors. Literally, as we were all packing our bags to come to this board meeting and leaving our various locations, we received notification from Health Canada that they have now licensed emicizumab for a broader set of indications, that is for hemophilia A patients without inhibitors. The first licensed indication was for inhibitor patients only. It is now approved for patients without inhibitors. But I want to be clear that that's a regulatory approval. So the drug has received its notice of compliance from the regulator. What we now need to do is work with CADTH and ourselves and the provinces to go through a review as to what it would look like to consider introducing emicizumab for hemophilia A patients who do not have inhibitors. So it's not approved to go on our formulary for that indication. Unfortunately, and I believe that to be the case, the jurisdictions did not approve adding either lanadelumab, which is an entirely different drug for another category of diseases, or alpha-1 inhibitor onto our formulary. And you're going to hear from the patient representative from the alpha-1 group. This morning you've heard from Angela many times before, and we had proposed to the jurisdictions that these drugs be added to our formulary, and they were not approved for that. I believe on the alpha-1 we have more work to do. There is a request from the deputies for us to work on seeking to actually fractionate alpha-1 from our plasma, and then we would have to redo the analysis and see where we go on that. But we'll talk about that when Angela presents. And of course, the other major issue that occupied us, and the board knows because I filled your email boxes regularly on this one, was the whole issue of subcutaneous immune globulin. And you're going to hear from at least a couple of patient representatives as well this morning about that. So I won't go into a great length other than to say we launched an AMBER advisory, which means we collaborated with our clinical colleagues and the National Emergency Blood Management Committee and the vendor and the patient groups and the physician prescribers to seek to mitigate the shortage that we were facing. And we have also secured additional supply from alternate vendors as well. But we'll speak more to that when Whitney and others present that. So what actually happened on the shipment point of view in this past year? This is the immune globulin category. This is not any one specific brand or class of drugs. This is the whole category of immune therapies. And you can see that the line continues to go up. That's why we're needing to collect more plasma. I want to just point out that in 2018-19, the black bar represents about 1 million grams of subcutaneous IG. And in this year that we're now in, 2018-19, that's jumping as high as already 1.5 million grams and potentially higher. So something like a 50% increase in demand for subcutaneous immune therapy versus intravenous immune globulin, as more and more patients appropriately seek to have their care administered at home. And there is a variety of good reasons why patients would want to shift to subcutaneous therapy rather than IV therapy, including the fact that it is inordinately expensive to treat patients inside hospitals. So we're seeing a dramatic shift, and that black bar is going to become a much more dominant part of the total volume of IG used over time.
Is the red bar going to go down?
So yes, what is important to say, that's a good question, Mel. We need to talk about both factors. So the total demand for immune globulin is going up by about 7 to 8% per year. That's not going to change. What the current forecast data is showing is that the black bar is going to occupy a much bigger percentage of that. So as a consequence, the red bar should go down slightly. But you're still going to see a total upward increase of 7 to 8%. And in fact, some of the modeling data would show that it could be as high as 10% per year, because subcutaneous IG tends to be used in some clinical conditions in higher doses than intravenous. So we constantly have to remodel these data. But I do predict for the next few years, the total bar will go up and the black bar will be a bigger percentage of that overall. This is the major hemophilia drugs, all lumped together, the factor VIII concentrates, and they're really derived from three sources. The red is made from synthetic engineering technologies, so-called recombinant factor VIII. The black bar is the plasma-derived factor VIII, and the blue bar are the so-called extended half-life products. So these are also synthetically engineered products, but they have a longer half-life, which means when you give them to a patient, you need to give infusions less often because the drug lasts longer in their blood supply. And so obviously that's a preferred therapy for a variety of reasons, including obviously quality of life. So you can see that the demand trends for factor VIII, sort of stable over the last 3 years, marginal increases, and that's not driven by more patients. It's not that there are more and more hemophilia patients being diagnosed. It's really there is a shift in practice. More and more patients get what is called prophylactic therapy as opposed to just therapy on demand, which is a better way of delivering care to these patients. So we do see a slow upward increase in the demand for factor VIII, and we predict that will continue for some time to come. This is the one that I've talked to the board about in the past and continues to be of concern to us, of concern certainly to the funders. And this is a category of drugs known as C1 inhibitors. It's used to treat a disease category known as hereditary angioedema, and patients can have very, very severe allergic reactions to the point that they can have fatal airway obstruction if not properly treated. So why are we seeing 30% increases or 25% increases year over year? And to Kelly's earlier question around where does the red cell line bottom out, what we're particularly keen to understand is where is this curve going to top out? At what point will the demand trend slow down? Because this is really costing the jurisdictions a very large amount of money. It's now the third largest category on our formulary, over $100 million. And you can see that the growth rate is anywhere between 25 and 30% per year. We believe there are a number of factors at play. Firstly, there are many undiagnosed patients still. So there are still patients who are not receiving therapy, or if they have been diagnosed, they're not receiving optimal therapy. And there is also a shift here to more patients getting prophylactic therapy versus therapy only when they have an attack of angioedema. So there's a big shift in clinical practice. There's a big shift in the rate of diagnosis. And we're working with the patient groups, with the prescribing physicians, the specialists who treat these patients, and with the manufacturers to try to model what the next few years look like. And we're actually going to convene a big consensus conference later this year to do that, because it's really important for all of us to understand at what point does this trend line slow down. And at this point in time, I can't even hazard a guess. But we are forecasting increases of this nature for the next few years. That's plasma products. I'll shift quickly to stem cells. Of course, what do we do there? We run 2 stem cell programs, really the adult registry as well as the cord blood bank, and we collaborate with stem cell registries and cord blood banks around the world. So some highlights in the past year. So as the board knows, we integrated the 2 programs. The cord blood bank and the stem cell adult registry were managed separately inside the organization. We've combined them now under Dr. El Moazin's leadership. She reports to ISRA, and we have a single integrated stem cell program in the organization. We rebranded One Match, which was the adult registry, as part of the overall brand, and it's now the Canadian Blood Services Stem Cell Registry. We worked with there's a very important initiative I wanted to just list on this slide here. I won't get into the details, but the World Marrow Donor Association is sort of the overarching body that oversees standards of care in the stem cell world, and they launched a safety initiative that goes by the acronym GRID, Global Registration Identifier for Donors, and we have implemented what is necessary for us to be GRID compliant, if you want. It was actually a very big change, had a lot of impacts on how we do our work, but it's an important safety initiative that minimizes risk of error in donor identification. And a major achievement this past year, thanks to the great work that Heidi and her team did, was we received accreditation for the cord blood bank, our second accreditation, in fact. So we now have all the gold standard housekeeping stamp of approvals for the cord blood bank. We have FACT accreditation, and we were previously AABB accredited. And that's important because it means our bank is now recognized at the highest standards. So here's some data that reflect our fulfilling patient needs. And David, you may be particularly interested in some of these data points. So if I look at the first headline number, 1,053, that was the number of searches that we did for patients in this Canada, whether they were searches of our own registry or searches of international registries. And that's about the highest number we've ever done in the past. What did that actually translate into? 402 Canadians got a stem cell transplant this past year through our registry, whether it was from a Canadian donor of our registry or a donor we found through our linkage to the international registries. And just to remind the board, we have about 450,000 donors on our registry, but we have access to 33 million donors internationally through all the other registries. So we facilitated 400 transplants. And in terms of Canadian donors, stem cell donations by Canadian registrants. So there were 116 donors from our registry who supported 38 patients in Canada, and the remaining patients, the remaining 80-odd patients internationally, were from donors coming off our registry. So that's a really good number. On the cord bank side, to date, we've collected over 27,000 units. We remind the board we don't bank all the units we collect because they have to pass very rigid quality criteria and have the right number of cells in the samples that we collect. We've banked at the end of the year about 3,200. We're probably over 3,400 now. This was data at the end of the fiscal year. And we continue to bank more and more units. We anticipate banking an additional 500 units this year. So what has the cord blood bank done? Well, actually, it's supported 21 transplants, 9 in Canada and 13 internationally. And actually, that number may seem exceedingly low, but for a bank of only 3,200 viable samples, that's one of the higher what we would call disposition data points. So most banks do not sell samples at that level. 21 out of 3,200 is pretty good. Kelly and Anne.
Graham, what do we do with the cord blood that we don't bank?
I think it might be on the next or a subsequent slide. So several things. Certainly we have what is known as a cord blood for research program. So if there are not enough cells that are viable for clinical transplant purposes, the product may be more than suitable for research purposes. So we provide many of our cord units for research purposes. That's the major use of them. And if they're not used for research and they're not suitable for clinical banking, they simply don't get stored. Because what you don't want to do is because it's, as you know, you've seen those labs, very expensive to store cord blood material. You don't want to store material that is never going to be used for clinical purposes. And that's very well acknowledged in the consent process, and when people donate, they recognize that not every sample will necessarily be frozen or used, and that those that are not suitable for clinical purposes may well be used for research purposes. That is part of the consent that the mums give when we seek to recruit them as donors.
Given current technology, what is the expectation of the duration for a newly collected sample, or not sample, but cord blood?
So you're actually going to see a presentation by Dr. Elmoazen later in this public board meeting. So I don't want to steal your thunder, Heidi, wherever you are in the room there. But the short answer is that probably indefinitely at the moment. So some cord blood banks are now probably approaching 15 or 20 years old, and there's no evidence that the cells lose viability. But I'll let the expert answer your question later this morning. We do believe that they have very, very long storage lives.
Graham, back to the stem cell part of our work. In terms of recruitment and registration, I know we have opportunity all over the country for people to become registered as stem cell donors, and then if their markers show up as matching in that, we can bring them in to do that. But on the recruitment side, how are we doing in terms of, is it flatlining? Do we find that we're continuing to increase the number of people who are wanting to sign up to be a stem cell donor if they're usable in the future?
I'm going to show you data in a few slides' time. I realize it's probably in a different place of the deck, but I have data on the diversity of the adult registry, and I'll show you that when I get to that slide, Craig. But we have a target of 25,000 recruitments every year into the adult registry. So to grow the registry by 25,000 per year. But it's not just, we don't want a come one, come all strategy. It's not just any 25,000 donors. We really want to optimize those. So you want younger, preferably male, and preferably from multi-ethnic backgrounds, because those are the underrepresented components of both the registry and certainly on an ethnicity point of view, even in the cord bank. And those are the ones that the physicians want in transplant. Preferably, they will take a stem cell donor who is a male under the age of 35. Why male? Because it has to do with immune complexities, particularly if the woman has been previously pregnant. There's a higher risk of immune intolerance in the recipient. So that's why male is preferred to female, and younger is just the younger the stem cell, the younger the donor, the better the outcome for the patient overall. That doesn't mean you won't take a transplant from a 40-year-old female. It doesn't mean that at all. But from a clinical preference point of view, the better donor is the younger male donors. And the ones who are underrepresented on our registry are those from multi-ethnic backgrounds. And I'll show you some of that data in a few minutes' time.
Graham, just jumping back a slide, looking at the 402 stem cell transplants, do we have any data on adult versus pediatric?
Certainly not off the top of my head, David. I'm sure we must have that because we would know where we shipped the units to. Maybe I'll prompt Heidi when she speaks later to see if she can answer that question. I would imagine the large majority are adult there. In the cord recipients, so that 116 or the 38 Canadian recipients, a very large majority are going to be pediatric. So I don't have the 402 off the top of my head, but attempt to get it for you, David. So jumping from stem cells to organs and tissues now, what's our role there? Well, we manage the National Transplant Registry, and of course we are responsible for developing leading practices, public and professional awareness, and a variety of other activities. 2018-19 was a busy year on the OTDT front, and I want to sort of highlight several of the big achievements. So one was, and I've talked to the board many times before, as has Isra and his team, on the challenges we were facing around bringing all the disparate players together. So CBS has a role, the provincial organ procurement organizations have a role, the provincial transplant programs, the provinces, and of course this is the one part of our business that also has funding from the federal government. So the federal government has an important role here as well. So there was an important body of work that happened over the past year that resulted in a collaborative being created, a formal collaborative that is really where Health Canada acted as the galvanizer, but it brought all of those disparate players together, the provinces and territories, CBS, the transplant programs, the organ procurement organizations, the professional bodies. And we've really created this collaborative, the intent of which is to improve overall system governance and management. So we were very pleased with the leadership by Health Canada in this regard, and very pleased with the true collaboration around the table. But I would also say that we've got a long ways to go still. We haven't cracked this nut yet. But I think what was a fundamental shift in the environment in 2018-19 was the creation of the collaborative and the joint commitment by the provinces and territories, the federal government, and all the various programs to seek to all play in the sandbox in the right way together. So that's an important initiative that has to do with governance and roles and responsibilities. We received $3.5 million incremental funding from Health Canada over 2 years, 17-18 and 18-19. And that was given to us to support a number of initiatives and that we were seeking to do, and we are expending those dollars this year in keeping with our commitments through our contribution agreement to Health Canada. In Budget 19, a bit of a surprise happened. Positive surprise, but a surprise nonetheless. When the finance minister was reading out his budget, there was an announcement of $36.5 million from Health Canada for organ donation and transplantation, with a big focus on data and system performance management. And it sort of came a little bit out of the blue. Nobody knew about it, nobody had a heads up, and it was sort of targeted at not Canadian Blood Services, but really at the whole area of data management in the donation and transplantation space. CIHI, the Canadian Institutes of Health Information, being the sort of primary entity that will help lead this work, as well as CHI, the Canada Health Infoway. So we, CIHI, and Infoway are all meeting now along with the collaborative to try to understand how to use this money optimally. It's a good problem to have, but I stress it's a bit of a problem because no one really had planned for this and no one really quite knew where the money is targeted for. But all parties, with the support of Health Canada, are seeking obviously to, and that's targeted over the next 5 years. So that's a very important opportunity for the whole area of organ donation and transplantation in Canada. There are two achievements I want to spend just 1 minute talking about that we're very proud of, at least our role in it. The first is the third bullet on that slide, and that is the team at Canadian Blood Services collaborated with professionals in the ICU community, the emergency room community, so critical care docs, emerge docs, ethicists, those involved in end-of-life care, to look at the very complicated, ethically fraught question of how do you consider the whole notion of organ donation in, and to use the technical term, in conscious, competent patients. But this is essentially talking about the area of medical assistance in dying. So if an individual has been identified and approved to have a medically assisted death, as the legislation now permits in Canada, but then signals their desire to be an organ donor as well, there were no guidelines anywhere on how you deal with that circumstance. And as you can imagine, it has many ethical, legal, and clinical practice implications. So we convened a group. They developed a set of guidelines. They were recently published in the Canadian Medical Association Journal, received wide coverage through the Globe and Mail and elsewhere, and has for the first time anywhere set a standard of practice or a guideline for how you deal with the concept of organ donation in medical assistance in dying. I think a particularly powerful example of what the work our team does with many, many collaborators across the system. And the other one And I want to take a moment to just speak to this slide here. Most of you will know it immediately, but Renee, you, not unlike the tremendous work you have done in your daughter's memory, this, of course, was all prompted by the terrible bus tragedy in Saskatchewan, the Humboldt incident. And this is the Boulay family shown there with Prime Minister Trudeau. And Logan Boulay was one of the young men killed in that bus accident. And as we all know the story, several months before this happened, he had told his family that he had signed up to be an organ donor. And his remarkable parents sort of fulfilled his wish. He donated his organs and saved 6 lives. And Glenda, you hosted an event on the Hill for us all about this. So we certainly want to acknowledge that important work. Just from some results point of view, if you look at this slide here, this is the trend of deceased organ donation in Canada over the last 10 or 12 years. The red line is the total number of deceased donors, and you can see if we use 2008, that's the year that CBS started in this business, as a baseline to today, there's about a 50% increase in performance. So 50% improvement in the number of deceased organ donors per million population, made up of the blue and the black line, which is the neurological death or cardiac death. It depends how a donor dies. Where does that compare internationally? This is the same sort of countries that I showed you the red cell results for. Well, we're in the pack at the bottom there with Australia and the UK, so about 22 donors per million population. So although it's a 50% increase for Canada, we still trail Spain and the United States dramatically.
So, Graham, as you noted, it's getting better, but we still have a long way to go. What are the main barriers in Canada that we lag some of our international comparators here?
So there are probably several. Certainly, I think the reason Spain remains amongst the highest performers in the world is they have done a remarkable job of changing what they call the culture of donation in the hospital. So that is about every physician in an intensive care unit or in an emergency room is trained to identify every possible opportunity. So somebody who is dying and likely to be an eligible organ donor, and then trained to have that conversation with the family in the moment of grief. So that's where Spain put their investment over many, many years, was to change the culture of donation at the moment of death. And they created a cadre of professionals who are comfortable and expert at doing this. Yes, they have legislation that permits a donation from everybody, presumed consent legislation in Spain. But they say that that's not the driver there. It is the culture of donation practice inside intensive care and emergency rooms. And they say that that was the single biggest determinant in their sustained improvement. They don't miss opportunities. The barriers in Canada is we don't have that as a culture spread across the jurisdictions. There are many missed opportunities. So that's one. If I compare Canada to the United States, which is not at Spain's level, but certainly a lot higher than us, they have much more formal governance practices. So although they have a federated system there, they have much stricter rules around audits of donation programs and transplant programs, not missing opportunities, and financial penalty if you do. We have none of those governing rules in this country. We have a much more sort of play if you want phenomenon given our very federated system, and there is no sort of overarching what they call the final rule in the US. We don't have any equivalent there. And the United Network for Organ Sharing has much more of a stick than CBS or any other pan-Canadian entity has. So I think, Glenda, it's a whole variety of reasons. I don't think there's any one. As you know, Nova Scotia's passed presumed consent legislation now. We are supportive of that. We think that's good. I'm not holding my breath that it's going to cause the rate of organ donation to rise dramatically, because I think all those other things need to happen in concert. So that's where I remain optimistic that this collaborative that is now created can begin to identify some of these systemic barriers and deal with them. But as you would know very well, I think it is the fractured, federated nature of our system that is going to be really hard to break through. If I broke that red line up, you would see some provinces alone are performing quite a bit higher. So Ontario is up at, I think, 26 or 27, so much closer to the US number than our average of 22. Some jurisdictions are at 14 or 15. So we've got big disparities across our provinces.
Graham, speaking of the culture in the hospitals, I was very pleased to note the health education website from Canadian Blood Services on organ donation, which I think is a great resource, and I've started just to use it myself. And I really feel and hope that will be promoted to health professionals, because that's really pragmatic guidelines. And even in Nova Scotia, we need initiatives, which where I'm from, of not just having the consent, but having the whole system ramped up, and hopefully we can just exceed everything. But I commend CBS on that and hope that's going to be promoted widely.
Well, thanks for that acknowledgement, Jay. I mean, that is a big part of the work that we are funded to do, is the whole area of leading practices and standards of care. So that knowledge dissemination is a really important part of what we do. And I would say the entire OTDT community knows that, uses that, and recognizes that. So thank you for that. Just moving on in the interest of time, this slide shows you results for the 10 years that we've been running the 2 registries for kidney transplants, so the highly sensitized and the kidney pair donation program. These were registries that never existed before and that support the transplant across provincial boundaries and amongst living donors and recipients, and they have different indications. I won't get into the detail. But as a consequence of managing these 2 registries, you can see that about 1,200 Canadians have now had access to a kidney transplant who otherwise never would have had and would have sat on a waiting list receiving dialysis for many years. So this is a very big contributor to the improved rate of transplantation in the country. Again, David, I'm going to use you as an example because you've prompted me in the past to speak about this data point, and that is, what do we know about Canadian patients sitting on wait lists in Canada, wait lists for organ donation and transplantation? Well, it's hard to measure is the first point, but here's what we know. So if you take 2012 as a baseline, which was sort of the worst year in a way, and you look at it now, we've seen about a 7% reduction in patients on a wait list, and you've seen about a 33% increase in the number of transplants done. We don't really know what that means, and we also don't know how to optimize patients on wait lists for solid organ transplant, and here's why. This is some comparative data from the same 5 countries. And I just showed you that Spain and the US have the highest rates of organ donation. They've also got the highest wait lists. So it's all a matter of how you list a patient. Criteria are not the same one jurisdiction to another. They're not even the same from one province to another. When does a patient get on the wait list? When do they come off the wait list? Are they taken off because they're too sick and they're going to die and they're not going to get a transplant, or do they stay on until they die? It's a really difficult concept, but our team is certainly working to understand how we shorten the wait lists and reduce the number of Canadians waiting for solid organ transplants. So it's an imperfect answer to a provocation you've often put to us, but the previous slide at least shows, if anything, there's a slight downward tick in the last few years. Does that actually mean the system is getting a whole lot better? It's quite hard to answer that question. Very quickly, and Kelly, this one picks up on your one question, just some data from our R&D and our innovation program. There's lots of stuff on this slide. I won't highlight it all, but we funded 15 new projects and trainees. We supported 68 research projects. We provided 3,500 products, fresh blood products to support production improvement. We delivered about 150 units to support cord research, 5 frozen, 150 fresh before frozen, and so on. So you can see our research program is highly productive and very engaged in supporting both our own operations and the clinical community. In terms of our relationship with donors, as the board knows, and this, Mel, was both in my direction letter from the board and in the mandate, in the letter of priorities from the provinces to CBS, we were given $7 million by the jurisdictions to improve the donor experience. So that was a major set of initiatives that we did in the last year, including things like our concierge and our automation of our environment and introduction of what is called a donor feedback system. So using technology to get live feedback from donors, and we can interpret and analyze the data using things like artificial intelligence. So some really important work there. Lots of work on enhancing the diversity of our donor base, and you can see some examples across different communities there. And of course, the board knows we changed the way we do our messaging. This is an important data point. As you know, of course, we've been investing in a shift to digital, as we call it. And this slide simply shows the number of donor appointments using our three main channels, digital being the channel we're seeking to move most donors to. So that's using apps, our website, the concierge tool inside the clinic, or calls from our contact center, or donors who book with a live person when they come to a donor center. And you can see that we had a dramatic uptick in the last couple of years, in the last year, in the last 2 quarters of last year, with the introduction of the concierge. Donor satisfaction continues to remain exceedingly high, so that's important. And this is the slide, Craig, that I said I would get to. It's a busy slide, but I just want to speak to the sort of the size of the green bars and the size of the red bars. And if you look at the last year, so the 4 quarters to the right, if you look at the upward trend of the green bars, that is the investment in donors to the adult registry who come from non-Caucasian backgrounds. And our target is 40%, and you can see in each of the last 3 quarters we exceeded that target. We didn't do so well on the male donors, so we have a target of every new donor we recruit, 50% of all the new donors that we recruit, 50% need to be male. You can see we didn't quite hit that in all quarters. We had some really good quarters, and we now have a partnership with Hockey Gives Blood, which is bringing in a large number of male donors onto the registry, registrants on. So we've got a lot of work underway, but you can see we're still seeking to optimize both our ethnic diversity and our gender diversity. Very quickly, Mel mentioned this in his opening remarks, so just to repeat that we changed the MSM policy as of June 3 this year. It's now a 3-month deferral. And the last couple of bullets just highlight the fact that we have a series of research projects underway now to look at those plasma donors where we could modify the way we use our MSM criterion and look at bringing in as potential plasma donors with a different approach to donor screening than our traditional question of MSM and a time period. So there's a body of work underway now supported by research dollars from the federal government. And I should also acknowledge on this slide the tremendous work that we've done with the trans community, and we have one of our advocates in the audience here who's really helped us both become better informed and more attuned to how we appropriately manage the complex issue of trans individuals. Just a couple of data points on our operational excellence theme. So Rick and his team continue to drive continuous improvement throughout our operation. As you know, we've partnered with Toyota Production System to sort of really learn the best way to do production. We're now rolling that out not just across our production centers, but our donor centers as well, starting with one here in Ontario at Hillcrest. We put new equipment in every production lab last year, a major capital investment that resulted in a huge degree of automation and quality improvement, as you can see there. Lots of automation in our testing lab, all of which is aimed at not only productivity and efficiency, but very importantly, error reduction and improvements in processing time. I will pause for 30 seconds on this slide, though, because this is the one slide that throws all the data together for our 4 productivity and efficiency measures in our blood program. And I mentioned that at the outset as one of our major achievements of the year. This is a 5-year snapshot for recruitment, collections, production, and testing productivity using the ABO benchmark, sort of what is the optimal benchmark there. And you can see in each of the main parts of our supply chain, we've seen a constant improvement in our productivity measures. Testing, for example, saw a 70% improvement from a baseline of 2014 through to 2018. And you can see the numbers for the other parts of the supply chain. Positive in all directions, and as the board knows, our aspirations are to continue to move those bars upwards. There's just some tantalizing photographs of Calgary. We now are in possession of the building, going through the validation and testing phases, which takes a very long time given all the sophisticated technology that's in the building. We then have to get licensure and approval from Health Canada to operate in the building, so we expect that in the early part of next calendar year. And then we begin phased move into the building, and we should be in full occupancy by the latter part of next year. Your public board meeting in this time next year will be in Calgary, and you will be seeing this building in partial operation, at least, if not in full operation. On the IT front, just to remind the board, we do a lot of work on cybersecurity. No significant incidents or threats in the past year, but of course we never rest on those laurels, and we continue to invest in our cybersecurity strategy that Ralph updates the board on each quarter. A big initiative this past year was the migration of our data centers into our new environment. We no longer manage our own data centers that used to be in Ottawa. We've now contracted with a professional data center company, and they manage our data centers for us, but of course they're still our servers and our data. And this has several major achievements, not least of which is that we have professional management over complex data center environments, but very importantly, one of the measures that was part of this project was what we call the return to full operation time. So if a whole data center went down in our old environment in Ottawa, we had a 7-day return to operation time. That is now 4 hours. So that's one of the benefits of migrating to a professionally managed data center environment that is distributed data centers across the country. So a huge initiative, but a very important gain. On a quality front, you talk a lot about this at the SRE committee, and I know that, but just to highlight for particularly the members of the public, lots of investment in quality this past year. Our new quality policy linked to the brand, huge investment in our what is called our CAPA program, Corrective and Preventive Action Program, which is a fundamental underpinning of any quality system, automating our quality processes, introducing CAPA specialists, putting them through very intensive training, and an overall dramatic improvement in our quality management environment. What does that all wash out as? A busy slide, I know that, but just to make the point here that all 8 of our 8 measures in the quality index exceeded target in each of the 4 quarters. And that's the first time we've ever had 8 out of 8 times 4. And kudos to not just Christian and his team, but certainly to their thought leadership, to Rick and his team for making sure this is taken up in the organization, and pretty much to the whole organization for sponsoring this, but really to Christian and his team for many years of hard leadership on this important endeavor. On the employee front, lots of work on the diversity and inclusion front. We launched a variety of initiatives this past year, including our first ever LGBTQ plus employee resource group, a Women in Leadership employee resource group, and a variety of other efforts on that front. Investment in a healthy workplace, lots of focus on OH&S and corporate social responsibility. So that's just some highlights there on the diversity and inclusion front, updating our policies, making sure we have voluntary self-identification for those employees who wish to do that, and a variety of other initiatives on that front. Lots of investment in ensuring we have a healthy workplace, and we have a whole strategy underpinning that. I won't read through the detail, it's in your slides. And just one of many data points we have on the occupational health and safety front is what we call the total injury frequency rate. And we actually are now benchmarking ourselves. There's an error here. That should say the Alliance of Blood Operators, but we now benchmark ourselves against our sister blood organizations on a variety of OH&S indicators, which we had never done before. Dunbar.
Graham, we've been hearing about a tremendous amount of change continuing to go on in the organization, whether it's products and services, whether it's all our productivity and efficiency programs. the whole plasma issues, whether it's formulary management or collection of source plasma and a number of others. Can you talk a little bit about the engagement results of our people that are at the base of getting all of this done? There must be tremendous change going on, yet they seem to be accomplishing a great deal. Can you talk about, I know you guys measure that, keep the pulse. How's that going? How are our people getting through this?
Thanks for that, Dunbar. And frankly, on reflection, we should have put a data point in. It's a really important reminder. So as you know, in this past year, we did another one of our employee engagement assessments. We actually completely modernized it and refreshed it. And as we've talked to the board in the past about, we're now actually looking at this whole notion of employee experience, of which engagement is one very important indicator. But we have both historic data and current data on engagement. And in spite of everything you said, which is the correct context, high degree of change, lots of busy work at Canadian Blood Services, we had the highest ever engagement score across the organization, exceeding even the 73% that we've seen previously. So we take that as, at a macro level, a very important outcome. High engagement in the face of high change. Of course, when you peel back that onion, there are many layers to it, and there are both some geographic areas and some functional areas in the organization that we know some parts of the engagement are not nearly as good as we would like them to be. So every Vice President gets their results by division, by geography, and by the various types of engagement questions that we ask, and they all develop action plans to focus on areas where engagement is not as good as we would like it to be, almost area by area by area. So that's my one data point, Dunbar. The other one is we introduced a new measure, which is known as the Net Promoter Score, which is a common metric in the world of customer satisfaction. You now see Net Promoter Scores being used in the world of employee experience. And although it's a first data point, we had a positive result. Of course, we will need to use that as a baseline and see where it trends in the future. But a lot of the work that Andrew and his team led was, how do we make sure that we're creating an environment where employees feel appreciated, welcomed, acknowledged, and engaged for the work that they do. And as you know, in the new strategy, employee experience is a fundamental underpinning of the whole strategy. This is about investing in our people. Have we perfected it? No. I believe there are always areas for improvement here. But I do think overall management is paying very careful attention to the health and well-being of the workforce. I have one, I thought I had it on a slide here. I should have pointed out on this slide, Dunbar, the main bullet at the bottom. We are doing work to align to the national standards for psychological health and safety. This whole notion of psychological and mental well-being in the workforce, and for folk to feel this is a safe place for them to do their work, is hugely important. And so we are now essentially aligning our practices and policies to the national standard, and will hold ourselves to that benchmark. So it's a bit of a long answer to your question. And Mel, I'll close with my last 3 or 4 slides. Of course, it is important for me to wrap up the year-end remarks with the financial outcomes as well. Pauline and her team did a much more detailed dive into this at the Finance and Audit Committee yesterday, and Dunbar will report on that later. But just 3 or 4 highlights. So this slide is a summary of the financial results for the fiscal year. And you can see, if you look at the 2 bars on the left, which is sort of the total outcome of that, we have a gain in our working capital of about $14 million at the end of March 19 compared to the prior year. What is making that up are the series of bars on the right, and I'll just hit a couple of highlights. So you can see that our unreserved cash is in a very positive position, about $140 million, whereas it was only $58 million at the end of last fiscal. That represents an improvement in our cash on hand from about 17 days cash on hand to about 43 days, which is obviously a much healthier cash place to be. Why? What's driving our positive cash environment? Firstly, you can see that our receivables have gone down substantially, almost $20 million, and that's very much driven by Ontario catching up on some of its receivables and paying at the end of the fiscal year. So that's a major contributor to a positive gain in our members' receivables. But we also had significant reduction in our inventory costs. You can see from 162 to 137 million, and that's driven by a combination of things: less volume of plasma products carried compared to the prior year, improvements in the foreign exchange rate, and also the total price mix of the products that we're carrying is lower. So improvements in inventory, therefore a positive impact on working capital. And you can see at the bottom, we have some provinces actually paying us in advance, particularly Alberta and BC have paid CBS some monies in advance, and so that obviously contributes overall to the cash environment. And accounts payable, a bit of a shift from the 2 years, but that's really just timing of receipts for mostly plasma protein products. So that's in Canadian Blood Services. In our captive insurance companies, and as of course the board knows, and just for members of the public, we have 2 captive insurance companies. The primary company is Canadian Blood Services Insurance Inc., which is a $250 million insurance company. We have assets at the end of the fiscal year at about $475 million in that company. And in last year, we saw about a 3% or $13 million return on the investment portfolio. Now, of course, although the primary is only at a $250 million insurance liability, that company underwrites other insurance policies. So we have a stock throughput policy, we have a cybersecurity policy, and we have what is called a contingent risk protection policy. Those are all underwritten by that company, as well as the catastrophic coverage. When you account for all the policies and all the liabilities, you account for what is required by statutory reserves, and you set aside a portion of your portfolio for market volatility, which is very carefully calculated. We're still sitting on what is known as a net premium assets or surplus of about $107 million in that company. So what did we do with that $107 million? One of the major changes that took place last year and at the beginning of this fiscal year is to reallocate the portion of the 2 insurance captives. And just at a very high level, we've basically increased the size of the primary CBSI from $250 million to a $300 million captive, and in so doing have now reduced the members' indemnification, which comprises the second captive CBSE. So significant positive use of that premium net assets to reallocate the limits between the 2 companies. And my second to last slide, just a quick show on the capital assets on our financial statements. A significant increase on how our capital assets look on our financial statements, driven by a variety of investments in facilities, data centers, production equipment, and fleet. And very lastly, this slide just shows at the highest level what our expenditures in 2018-19, so the $1.168 billion on the right, compared to the prior fiscal year where we had a $1.25 billion expenditure. So a $90 million reduction in our total expenditures, made up of several things. The first one is a reduction in the cost of plasma protein products by $73 million. That's positive. In fact, the total cost of goods went down by $110 million as a result of the new pricing we got from the RFPs, but that was offset by rises in utilization. A reduction in staff costs of about $5 million between the stem cell program and the blood program. Medical supplies went down by $6 million as a consequence of new contracts, new RFPs for our test kits. Slight increase in our G&A of about $5 million, driven by increased marketing costs and some increased capital costs that accounted for some of that, as well as property expenses in Alberta. And then the other major contributor was a gain on our foreign exchange that is a maturation of the forward currency contracts that are not designated as hedges. So positive gain on our foreign exchange there, all of which contribute to a lower expenditure this past fiscal year. So, Mr. Chair, I've gone a few minutes over time, I recognize, but positive year, I would say, in the least, a very positive year. Met collections target, met hospital shipments, gains in productivity, positive donor experience, to Dunbar's question, positive employee experience in the face of a brand renewal and a new strategy. And I thought so we've heard from Renee, and it says it all, but I'm going to take one more opportunity to read a letter that I received from Harrison. Harrison's a grade 5 student in Ontario, and he wrote to me directly, and he said, "Dear Canadian Blood Services, my name is Harrison and I'm in grade 5. I'm writing to let you know that you tried your best to help my Uncle David with your services when he was battling leukemia. For my lesson at school, I made a poster and a speech and an activity to look at blood types. I've learned a lot about what you do, and I thank you for trying to save people's lives. I'm looking forward to presenting my project to my uncle's grandchildren, and I hope to educate them about the work you do at Canadian Blood Services." So to Renee, your story is just incredibly powerful and impactful, and as Mel said, you remind us why we do what we do, and Harrison does as well. So, Mr. Chair, I'm done.
Thanks very much, Graham. And thank you, Harrison. I trust you will respond to Harrison.
I have indeed already.
Good. Any other comments or questions from the board for Graham? Vic?
Thank you, colleague. I didn't know where to fit in this request, but you just prompted me with what you just said. Earlier today, you and I had a discussion with the gentleman who had his 400 pin on, and he asked you a surprise question. He said he was delighted to be here, but he really didn't understand why, as a donor, he was invited. And I thought I'd ask you to share with everyone what your answer was to explaining to that gentleman why he was invited.
And Grant's sitting right over there behind
Alan's
me.
sitting right there. Alan's sitting right there. So, and there were, of course, a 200 and a 300 times donor. So between the three gentlemen alone, there was sort of 900 donations there. And my answer was very simple. You are here because you represent what we do. Without donors, there is no system. Without donors and the work that we do, we can't support people like Renee's kids and people like Harrison's uncles and people like many of the patient representatives you're going to hear from later this morning. So for me, donors, it starts with the donor. It all starts with the donor, but most importantly, it all is about the patient. It is about serving the patients, and every decision we make is about taking a patient's focus in mind. But we can't do that if we don't understand where we're going to get the donors from. So for me, it's bringing both together, Vic. It's the donor and the patient. It doesn't happen without the donor, but it's all about serving the patient needs. And frankly, that's why we get out of bed every day, and it's easy to do.